All right, we'll get going. Welcome again. Thank you for coming inside on a night like this and spending some time with us. My name is Bob Rared. I'm the Director of Health and Human Services for St. Croix County. And tonight is our first symposium on mental health with a focus on suicide. I had prepared some notes after I gave a lot of thought to what I was going to say as a part of an introduction to this event. And then I decided not to read them. Instead, just to maybe talk from the heart a little bit and explain in regular language as to what it is that we're doing here tonight. I wanted to thank a couple of people first. Certainly our panel tonight. We have Patty Shockner, our Chief Medical Examiner here. We have Char Lopez, our Behavioral Health Administrator, who's going to speak. Kelly Ingan, our Public Health Officer. And Rick Ritmaster is our guest speaker tonight. And Rick, thank you for coming. We look forward to hearing your presentation. Who did I leave out? Anybody? I think that's the panel. And I wanted to thank County Supervisor Fiedler and Patty Shockner for really initiating this effort by expressing their concern and their desire to do something about mental health crisis and suicide in our county. And this was really their effort to begin a discussion with all of you around this topic. Along those lines, my personal interest in this topic has to do with a larger desire to bring these discussions around mental health, addiction, and suicide into the realm of healthcare, not a separate, not an independent, different area of healthcare, but a part of the whole discussion around health. And if you think about it, the differences are pretty stark in the kind of care someone receives if they're in mental health crisis versus having a physical health crisis. If you go into a hospital, you have chest pains, you get one response, right? You get a whole team of doctors, nurses, and others running diagnostic tests and immediately getting you the assistance that you need to make sure that you're going to be okay. If you walk into a hospital or any clinic or place to get help and you're intoxicated, or if you're having a mental health crisis and it's hard to express yourself, it's hard to explain what's going on, it's a much different response, you know? You don't put people on a wait list for having chest pain. You address the problem in the moment and you do all the tests, you get all the people involved that need to be involved to make sure that person's okay. My desire, as I've said many times, is to get to a point in our communities and beyond where we treat mental health crises, addiction crises, and any behavioral health crisis event with the same urgency that we treat physical health kinds of crises. So tonight what we're going to do, what we hope to do, is not just present you with some data to show the extent of the impact that suicide is having and mental health crisis is having on our communities, but it's also to hopefully begin a dialogue with our communities around this topic so that we can talk about these kinds of things openly, so that we can look at systems of care and say to our policymakers, these need to change. We need parity between mental health and physical health. We need to have true parity. So part of the idea tonight, from my point of view anyway, was to begin that kind of dialogue with all of you. And by dialogue, I mean we want to be open. Our Health and Human Services Department wants to be open to suggestions, open to ideas for who we're missing or what we're not doing that could be making an impact in this area. It's my personal belief that stigma plays a big role in that. We don't feel comfortable talking about these kinds of things to family members, even to our healthcare providers sometimes, because we don't know what people are going to think about us when we say this or that's going on with us, or we're having this kind of a struggle. having difficulty with an addiction. And, you know, as I prepared for tonight, I debated, and, you know, I debated what I would say, but I wanted to have some kind of an impact. I don't often share this, and I don't talk about this openly, not because I'm ashamed of it, but because I too worry about what other professionals might think of me or what my employer might think of me. But 32 years ago, I was homeless in San Diego and drinking myself to death. And I remember the feeling that I had at the time was, I'm a ghost. Nobody sees me. Nobody cares. And the total lack of hope is what I think stuck with me. The lack of being visible. I'm sorry, I get choked up. And I remember a doctor, I was at a conference in Arizona one time, a Native American conference, and the doctor said something that stuck with me. And she said, hope is a form of medicine. And I believe that, right? I'm not saying we should have the same healthcare system for people with behavioral health disorders as we do for physical health. I'm saying we need an equal system. And hope is a part of that. So as we talk tonight about these topics, mental health, addiction, suicide, I want us to think about that aspect of what we do and how we can reach people, that aspect of giving hope when there isn't any, you know. Sorry. But tonight, let me get back on track so I don't ramble all night. Tonight what we'd like to do is we'd like to present some data that shows, it's from a 2020 study that Wisconsin did on suicide deaths. I want to present some of that data to show the extent of the impact of suicide, some of the populations affected, and some of the strategies that Wisconsin came up with to address suicide. And then our chief medical examiner, Patty Shockner, will get a little more closer to home and present some data from St. Croix County on suicide. And again, some of those similar factors. Then we're going to have Rick Ritmaster, a guest speaker, talk a little bit from his perspective. And I'll read his bio before I introduce him. And then we'll have a panel discussion. Oh, I'm sorry. And then Char Lopez, our behavioral health administrator, and Kelly Ingan, our public health administrator, will talk a little bit about some of the resources and efforts that are going on in St. Croix County currently and things that we're trying to do to improve our response to mental health and addiction crisis and certainly to prevent suicide. After that, we'll have a panel discussion. We'll all sit up here awkwardly and then wait for questions. And we'll try, again, that's the part where I really would like to have a dialogue with all of you around things that you can think of or your perspective maybe on what we could do differently. If we're not helping people, we're not doing something, right? It's not the person's responsibility to figure out how to get help. It's our responsibility to figure out how to help them. That's my opinion anyway. So, all right, I'll shut up because I just rambled when I didn't intend to, and I'll get back to being on track here once I put my glasses on. Did I miss anything? No? All right. All right. Here we go. So tonight's mental health discussion is on suicide prevention, but we intend to continue these symposiums going forward so that we maybe cover different topics, different areas of interest around mental health, addiction, suicide, and things like that. So this isn't a one-and-done kind of thing. We intend to continue these efforts publicly so we can have these kinds of discussions. I think I've already done all of this, but again, this is a list of our presenters, a list of the order of things that we plan to do on the agenda tonight. Again, I was looking at a study from Wisconsin that was done in 2020. So this was pre-pandemic, right? And we all know, I think we all know that since the pandemic began in 2020, there's been an enormous amount of social economic pressures that people have had to contend with. And as a result of that, there's been an uptick, a pretty substantial uptick in people needing behavioral health services, right? Our wait lists are growing at the county level. I know many of our providers and partners are experiencing the same thing. So we're starting to see a wave of people affected by the pandemic, or where their situations were exacerbated by the pandemic, showing up now for help in one form or another, but showing up to get help. But in looking at the data from the Wisconsin study, between the years of 2013 and 2017, well, let me back up, I'm sorry. Wisconsin's suicide rate increased by 40% from 2000 to 2017. 40%. Between the years of 2013 and 2017, most suicide deaths were male, with the highest rate among individuals between 45 and 54 years of age. Suicide rates were highest in higher in rural counties than they were in urban and suburban counties in that same time frame, and suicide rates were highest among American Indians, Alaska Natives, and Caucasians. And this is a hard slide to read, but again, from 2013 to 2017, 271 adolescents died by suicide. I can't get Uvalde out of my head. I know it wasn't suicide, but I'm sorry. Second leading cause of death among 10 to 19-year-olds was suicide. Approximately 1 in 6 Wisconsin public high school students reported suicidal ideation, 1 in 6 in 2017 in a 2017 Youth Risk Behavior Survey. Adolescents who died by suicide were more likely to talk to a peer or friend about their intent. And females between the ages of 15 and 17 had the highest rates of emergency department visits and hospitalizations due to self-harm injuries. Among veterans, almost 1 in 5 suicide deaths were veterans. 1 in 5. 70% of all veteran suicides involved the use of a firearm, and almost all of them were male. Veterans who died by suicide were more likely to have reported a physical health problem and less likely to have reported a mental health issue as compared to non-veterans. And that statistic, or that bit of information, surprised me. It goes back to the fact that health is not just behavioral health and not just physical health. Health involves everything around us, our ecology. It involves our physical health, certainly, but we're influenced, our health is influenced by environment, by social connectedness, by economic pressures, stress, certainly trauma. So Wisconsin, and this is of course a summary. This report's available, I think, Adam, I think we have a reference for it on our website. Where's Adam? There he is. Don't we? Okay, we'll put a link to this particular report that I'm reading from here, or that I've summarized here. But the first strategy was to increase and enhance protective factors. And involves things like, like what we're doing here really, is bringing communities together to talk about this and come up with ways in which to improve and promote social connectedness. So another bullet under that same strategy was reducing lethal means for people at acute risk of suicide. Things like gun locks, safe storage of meds and firearms. I do want to mention at this point too, we have resource tables set up in the room adjacent to here, and we have free gun locks, and also we have Narcan available that you can take home with you. There's a brief training that goes with that. But the Narcan is used for opioid overdose. It reverses the overdose. So we have that available in the resource tables back there. And the third strategy was to implement, the second strategy was to increase access to care for at-risk populations. Improving access to care is easier said than done. again, this goes back to having a system of care that is responsive and funded well enough to respond in the way that we know we need to in cases of mental health or behavioral health crises. And then use of technologies such as telehealth and peers, as well as peer support and stigma reduction. We used telehealth a lot when the pandemic started. We kind of threw everybody into this world of telehealth that wasn't already there, and found that it was actually fairly effective, or very effective really, in reaching people in geographically distant environments. It didn't require them to drive in. We kept them safe by not exposing them to the pandemic, etc. And it's, for most people anyway, it's a easy way to access help. It's hard to walk into a building and ask somebody for help, or pick up a phone. It's easier to go, I think it is, to log into a website or a social virtual session with someone sometimes. And peer support is an area that we're really trying to develop in St. Croix County. Peer support involves people with lived experience in mental health or addiction who have training and know how to approach people in a way that's not confrontational. It's not directive so much as it is building a relationship with them, helping them through their own lived experience in finding solutions and getting the help that they need. And it's really, I've used it before when I worked in the Twin Cities. I've used peer recovery specialists in a variety of roles. It's a very effective way to fill the gaps between professional clinical roles and community-based things like AA or NA or something of that nature. So it's it's kind of a missing link sometimes in terms of getting people the help they need. A third strategy was to implement best practice prevention in healthcare, and this is things like using evidence-based tools, assessment and treatment and follow-up. So using scientific approaches to how we design interventions and strategies to help people. We can no longer be what we used to be, which was, this seems like it would work. It has to be something grounded in science, something that's been studied, and something that's shown to have good outcomes. That's what we need to focus on. We need to really rely on the science behind mental health and addiction to drive the kinds of interventions that we provide, and partner more closely with hospitals and other physical health care kinds of environments. And lastly, the fourth strategy was to improve surveillance of suicide and evaluation of prevention programs. Data collection is very important to understand where problems exist within populations. We've talked extensively, Kelly Ingan, our public health administrator, and I, about ways in which we can blend our public health division with the rest of our behavioral health services to help guide intervention strategies, to help us better understand the characteristics of certain populations so that we can address the actual needs of people within our communities, right, and not just guess at what we think would work well. And then coordination between government, public health, as I just said, healthcare, employers, education, business, media, and community groups. It's not just send them to behavioral health. We as a community have to figure out strategies for helping the folks in our community that suffer from mental health and addiction and who may be contemplating suicide. All right. Whoops, I hit enter, Adam. What do I do? You're good. All right. I'm done. All right. So I'm going to be quiet for a little bit. You've had to listen to me for a while now. I'm going to turn it over to Patty Shockner, our Chief Medical Examiner, who's going to talk more specifically about St. Croix County, some of the data that she's put together, and I'll turn it over to you now, Patty, if that's okay.
Okay, thank you, Bob. And, the biggest thing I can say is sharing your story is so important. I didn't know that was your story, and I'm so grateful that you shared that with us, because I had a conversation with you about being in San Diego and how impacted I was personally by the homeless population. And I didn't know what your experience was. So you never know what someone else's experience is. And the biases that we have internally and we say them out loud, you don't know how that impacts the person you're talking to. And, you know, I think it's really important to realize that everybody in this room has a story that's connected to mental health somehow, somewhere, with somebody they love. And pretending that we don't is part of the problem. We, as individuals, have to really stop and think and be mindful of those around us when we're making comments and having discussions about mental illness. Because mental illness is a really broad topic. So for those of you that don't know me, I'm Patty Shockner. I'm the Chief Medical Examiner. You know, some people wonder why I walk around with this kind of bubbly, weird personality and all I do is deal with death. Well, that's my coping skill. So, and we all have coping skills. And I started my career in emergency services, and my first call was a suicide by gun and an attempted homicide. So I went in to change the world, and that was my first exposure of lethality. And, you know, and that was in 1989. Some of you probably weren't even born then, but that's when it was. And now I look at it and, you know, I'm like, we're still talking about the same stuff. And it can be daunting for people who do this work. And I think for anybody that does the work in mental health and working with folks that are struggling with mental health, even though there are some days, and families that have mental health, there are some days that think it's never going to get better. What we got to think about is the days that are better, because it isn't going to go away, but we can make little incremental changes. So when you think about the data and what's going on, I'm going to read off my slide and then also kind of so you can look at the data. So the suicide rate, and when you talk about rates, it's per 100,000. So to put that in context, and pretty much everything we talk about in data is per 100,000. So 13.48 per 100,000, you know, when you think about it, you know, that doesn't seem like all that many. But when you start breaking it down and the impacts that that has to each one of those individual families, that's what you have to think about. The suicide rate, and I've actually watched this happen in my professional career now, is amongst middle-aged men. And I can remember when we were horrified about the teenage suicide rate. And we've actually, you know, kids and young people are far more aware and far more apt to reach out for treatment and talk to their school counselors and their teachers and people they trust than adults are. So I'm hopeful that as this next generation and people are really talking about it, that we're going to see that reduction in stigma that we're seeing now. But that still means we have a full generation that we have to deal with and try to figure out how to deal with stigma. Men are more likely to die 3.8 times or 4 times more than women by suicide, and that's a frightening slight piece of data. And when I started working on suicide prevention, we had this slide, and it was an airplane, and we said, you know, 92 people die every day by suicide in this country. And if that was a plane that went down every day and 92 people died, we would be horrified and outraged, and we would do something about it. It's now 2022, and 136 people die every day by suicide. So even though we're doing all this work, our plane is getting bigger, and it's still crashing every day. And the reason that we don't pay attention to it is because it happens over, one might be in one little county in New York, and one might be in one little county in Nevada, and another one over here. So it's all spread out. And the pain and the grief that people are feeling are community specific, where if a plane crash and 136 people died at one time, we would be horrified because we've seen it. And we understand that. But because we're not dealing with this on a daily basis is why it's hard to really talk about stigma. White males account for 69% percent of suicide deaths, and a firearm is responsible for 52, this is national numbers, 52% of our suicides. In St. Croix County, it's 78%. So we have a much higher rate than national. And 93% of people surveyed say suicide is preventable. So this is our first look at the general information, and it really, the number of completed suicides per deaths, and the average age, and our average age is continuing to increase. Our male numbers are going up, and you can see 2019, 2020, 2021, only men died by suicide in this county. And in 2022, so far, we have had 6 suicides, and 6 suicides by men and 1 suicide by a woman. So men are very, very at risk, and that's really why we have to have this conversation. And then when you take a look at mode, you can actually see, between firearm, asphyxia, overdose poisoning, and then other. It's very, one mode is very specific, and that is the firearm mode. So that's a conversation in and of itself. And that is not a conversation for today, but it is a conversation that people can have. When we talk about the overdose and drugs, again, when we talk about addiction, that's not what we're talking about today, but it is part of the thing. And when you look at mode, firearm is the most lethal. You can't come back from it. But asphyxiation, drug overdoses, like we said, we had Narcan out there. There are ways that we can come back from that, and that's really good prevention strategies. A lot of times you hear people will take an overdose and then go tell someone. It's when they're alone that they become complete. So when you look at our data, it's pretty clear, but I can tell you from an investigator's perspective as a death investigator, we go to every scene and we have to share the families and the survivors share the story with us of this person who died by suicide. And usually what happens is the decedent had some sort of history of mental illness. Most of the time, especially with men, they're not diagnosed, but the family always knew they had quirks. Like, they had quiet times that they would go down the basement and the family just knew to leave them alone. Or they would, just do things that you could tell when they were in their mood, but nobody really knew what that was or if it was mental illness. And the survivors at home didn't know how to address what to do if your loved one is in that situation. So really addressing what mental health is and how we can access care is really, really important. And especially for men, because saying that I need help can be very hard. It's hard for everybody, but if you don't have a bone sticking out, for most men, they're not going to ask for help, because how do you explain that your soul is broken, that your core is broken? It's very hard to explain. How do you explain that the pain that you feel is so bad that you just want it to end in this moment? It's not that you want to end your life, you want to end that pain. And that is what a suicidal person is feeling. And we have to remember that when we're talking about mental illness and suicide, and especially suicide prevention, so that we can get people to open up to us what it is. Because being a death investigator, one of the hardest things we do is suicide investigations. And most of them are happening in rural areas, which means that the sheriff's department, like us, are exposed to them all the time. It's mostly rural, mostly, no neighbors. They might be someone who was recently divorced, recently split up, or recently retired. That seems to be one of the things right now is recently retired. You've spent your whole life working and you didn't really have a family. You moved here, you've lived here for 30 years, it was great, you retired, and you're not working anymore. Your workforce was your people. Where most of us have families, for them, it was their workforce. So loneliness is really huge. And we have to really think about that when we're talking about rural. And that's where telehealth is so important. There are ways that we can connect with folks so that it doesn't get to the finale of suicide. Because when it comes to our department, what we tell families is our job is to determine cause and manner and write that final chapter of their life's book, but that final chapter does not, and I repeat, does not define their life. And we are the only ones who can talk about suicide and suicide completion and take away the stigma. So everyone here has a responsibility to talk to their family and their peers about, it's not making suicide normal. What it is talking about the pain that a person is in that makes them get to that point. So with that, I am going to turn over to Bob again.
Thank you very much, Patty. Appreciate that. It was great information. And it's my pleasure now to introduce our guest speaker tonight. I'm going to read his bio here so you have an idea of who he is. Rick Ritmaster is a retired Army chaplain and ordained pastor in the Evangelical Lutheran Church of America. Military assignments included deployment to Iraq with the 34th Infantry Division in 2009, rear detachment support for the 4th Combat Aviation Brigade, Fort Hood, Texas in 2012, and a deployment to Kuwait and Iraq as the 34th Combat Aviation Brigade chaplain in 2014 to 2015. Since 2015, he has worked with a team of DBT therapists at Nystrom & Associates in Eden Prairie, Minnesota, using dialectical behavioral therapy, DBT, to teach clients emotion regulation and mindfulness skills to address their PTSD or post-traumatic stress disorder symptoms. His experience in both the spiritual and psychological dimensions of trauma recovery, and other important insights in addressing the debilitating effects of PTSD and moral injury. So it's my pleasure to introduce Rick Ritmaster.
Thank you, Bob. Appreciate that. I also appreciate your candidness. It's just that's what we need to hear. So thank you for doing that. Yeah. So I do a lot of work with people who experience trauma, and that's initially what I was going to be talking about. But I was asked to talk more about what are we going to do about it, right? How are we going to intervene in people's lives? And I think that's a really great idea, so I'm going to focus primarily on that. Trauma, and I've experienced, in a variety of different venues where people have these traumatic pasts, oftentimes has its origin in childhood. And when you hear about veterans committing suicide, every veteran I've worked with that's been diagnosed with PTSD has had some kind of childhood trauma. So it's part of a bigger picture. And this is all anecdotal, but from my perspective, it's a bigger picture than just simply, they were in a combat situation, and so they're damaged goods. The trauma that people bring with them oftentimes gets exacerbated, it gets triggered later in life by things that they've experienced in their childhood. So with that, if you think about somebody who's experiencing a mental illness where at some level they've become an enemy unto themselves, imagine what that would be like. You know what it was like when you're a little kid? You ever going to Target, maybe your parents are with you, and you get lost. You're looking down the toy section, and you turn around, and they're not there anymore. And what that feels like is like your whole world has collapsed, right? I remember as a little kid that happening to me, and that panic that sets in. Well, as an adult, you could go up to a little kid like that and say, it's okay. We're going to find your parents. Everything's going to be all right. But a little kid doesn't have the capacity to see that distance, doesn't have that horizon of perspective. And that's what somebody who's experiencing a mental illness is experiencing. They don't have that horizon, that perspective to be able to see beyond the pain that they're in. And the pain is real, and it feels like it's absolutely overwhelming. So, I got the slide here, right? We'll see if I can do it. And I'm going to get a young man who's going to help me with this.
Grab the mouse and you click.
Okay. All right, good, thank you. So, how do you help somebody that's experiencing that? When maybe you can see a broader horizon than they can see, and they're mired in this pain, and they don't know what to do. Well, I'm a dialectical behavioral therapist in Eden Prairie, and we work with a lot of people who have traumatic pasts. And the primary DBT number one assumption we go with is that people are doing the best that they can. Now, if you talk to somebody who's suicidal, or somebody who's abusing substances, or is making impulsive life choices, and you can see as clear as day that what they're doing is not in their best interest, it's not helping them, it can be really hard to believe that that person is doing the best that they can. But if you think about where they're at, what they know, what they've learned, the environment that shaped them, the personalities that they have, it may very well be that they are absolutely doing the best they can given what they have to work with. So we start there as an understanding that, yep, this person is doing the best that he can, best that she can. The second DBT assumption is that people want to get better. Well, when you're talking to somebody who's suicidal, it can seem absolutely the opposite of that, that all they're really concerned about is this consuming depression or this internal psychic pain that they're experiencing, and maybe doing things that seem to be obviously standing in the way of them getting better, rejecting help all along the way. If we take it as an assumption, it's not a fact, it's an assumption, that they want to get better, and then I have to take a step back and say, well, maybe the situation is that they don't know how. And oftentimes that is exactly what the situation is. So why would people resist getting help? Maybe you've experienced this. Maybe you've talked to somebody who's been in the throes of chemical dependency, or depressed, or doing things that are tearing down their mental health. Why would they resist getting help? A lot of reasons. There's the fear of the unknown. A person who's suicidal, actually, that's a coping mechanism. A person who is thinking about taking their own life is actually experiencing a little bit of relief from this internal pain, because there's a thought that, it's not going to last, this pain's not going to last forever. I always have that option. It gets reinforced the more that people engage in those kind of thoughts. It's not a good coping mechanism. It is a way of understanding, though, that I have some kind of control over my life. And if I'm, as an intervener, trying to talk somebody into looking at their life in a different way or getting some help, they may have this real fear because they don't really know what's beyond the horizon there. Then there's the obvious, the stigma, right? The fear of becoming stereotyped, judged, dismissed. There's the understanding that if I give up whatever way I am coping with my experience, as lousy and as unproductive as it is, then what's going to happen to me? It's feeling like that they're going to disappear, or that whatever pain that they've been holding off through either the suicidal thoughts or the substance abuse or whatever that they are choosing to do will overwhelm them. And along with that is this fear of losing what little power that they might have over their lives. If I acknowledge this, and I have to go to a therapist or an inpatient treatment program, I will have given up what little power I have in my life. That's the mindset. And there's a fear of not getting better. If I kind of keep this at bay, if I just understand that these habits that I have, whether the thinking habits or behavioral patterns that are bringing down my mental health, if I address those face on, there's a possibility that I may realize that I can't get better. So there's a lot of reasons why people would avoid wanting to get help. Going back to that analogy of the little kid in the store, imagine the little kid not only is afraid because they're alone, but now they've been given or they have embraced a belief that somehow they're responsible for getting lost. That their separation from their parents or their community is somehow the result of some deficit within themselves. Now you're adding shame to it. And I would say for everybody who's experiencing a mental illness and are resisting getting care, it's because they don't have the skills yet. And they are skills, and this is the good news. Because you can learn skills. You can change thinking patterns. You can discover new ways of coping. You can get help. So how do we help them do that? Well, first of all, let's talk about what probably isn't effective. And now when I talk about this, I'm not talking about a direct intervention with somebody who's actively suicidal. Somebody who's actively suicidal, they need an intervention right away. Taken to the hospital, let the professionals help them. But if you're in that in-between part where you're seeing somebody that you care about that is kind of on the brink or is acting in ways that is causing concern for you, it's important to not just immediately offer unsolicited advice. Because people will receive that as an invalidation. If they're not looking for advice and you're saying, you got a problem, they're going to resist that. And you don't want to try and argue somebody in your point of view. Remember, people who have a mental illness and are responding to it in unproductive, ineffective ways are doing so for a reason. They have their own internal logic. And to try and argue against that internal logic is probably going to be productive for you. And that's important not to underestimate their pain. When we've got that vision of what life can be like, it doesn't help to say, come on, it's not that bad, or to try and argue them out of there. The pain is acute, it's real, and it's overwhelming for them. And the other thing, and this oftentimes goes for parents, is to avoid trying to problem solve for the person. You don't want to do their thinking for them. It's really tough when you're working with adolescents because they know everything already. And to try and do their thinking for them oftentimes doesn't work. And then finally, it's important not to unintentionally reinforce behaviors that are unacceptable to us. So like, for instance, and I've seen this with my clients. A young man experiences tremendous anxiety, and he avoids social interactions. His world gets smaller and smaller, and finding now he's living in his parents' basement, and he's drinking. And now he's 20 years old, doesn't have a job, doesn't have any friends, and he spends his time on a computer and consuming alcohol. To allow that to continue is not in his best interest. And to create an environment where he doesn't have to change, and I'm not talking about trying to cajole him out of, you got to do this or that, without putting some teeth behind it, all we end up doing is just reinforcing a pattern of behavior. Imagine that same kid at age 30, 40, 50. I've had clients still living in their parents' basement. And that's the result of it. It's that reinforcing behavior. Or let's imagine that maybe it's a spouse that is experiencing PTSD, and the way that this guy responds is that he gets violent when he gets really agitated. To allow that to happen is only reinforcing the behavior. So we don't want to unintentionally reinforce behaviors that are not in the best interest of the people that we care about. This is what we can do, though. First of all, is create a safe place to communicate. That's not about solving a problem. It's about creating an environment where they feel like they can actually articulate in whatever way they're able to do that, what's going on with them. In DBT, we got an acronym, it's called GIVE. When I preach sermons, this is the only sermon I preach anymore. It's first of all is to be gentle. There's lots of ways we can be harsh with each other, especially the people we care most about, right? And so to be gentle means actually you're kind of withholding great power and making a choice to create an environment of communication with them that they can trust that they're not going to be criticized. And then to be interested. So interested is listening to exactly what their pain is all about, not minimizing it, not trying to talk them out of it, but simply listening to what's going on with them. Validating is about being able to see their internal logic. So somebody is retired and is feeling like he doesn't have a purpose in life, doesn't have a community, and he's saying, I feel like I don't have anything worth living for, and there's nobody that cares about me, and these kinds of assertions, you're thinking, well, that's not true. All you need to do is this or that. Validating is say, yeah, I can see how you would feel that way given where you're at right now. So you're not agreeing with them, you're just simply acknowledging that you can understand that internal logic. And then the fourth one is to be easy-mannered. Tall order when we're worried about somebody. But it's basically putting your faith in the fact that I'm going to work on creating this environment that's going to be nurturing, and I'm going to wait some of this out. Again, we're not talking about active suicide. We're talking about somebody who's kind of in the middle there and not sure if they want to get help, but they know they need something. And then it's to acknowledge your limitations. So if somebody is actively suicidal, that's not a time for us to try and argue them out of what they're planning on doing, for instance. That's the time to get them help. That's a limitation that we have. But it's also acknowledging our limitations in terms of what we can't do for somebody. We can't solve the problems for them. We can't go through the process that only they can go through. We can be there with them. We can't take it on ourselves. That can be really hard to accept, especially when we're talking about people that we care a lot about. Maintain clear and consistent boundaries. What that means is that if somebody is acting in unacceptable ways to us, that we're not going to tolerate that. And there's lots of ways in which we can communicate that is actually helpful for people, as opposed to creating more distance. The consistency is what's key there. And along with that, then reinforcing the behaviors that are acceptable to you. So if when somebody chooses not to get violent, that's the time, and you say, this meant a lot to me that you reacted in a way that I thought was helpful and didn't make me feel unsafe, and I appreciate that. If the only time that we give people attention is when they start having problems, that communicates something as well. So we want to create this environment where we're present, we're consistent, and we're available to the degree that we can be. And finally, to practice good self-care. You know that old adage about the gas mask coming down on the airplane. If you don't put your oxygen on first, it doesn't really matter what you want to do to help anybody else. So good self-care, which again makes it possible to do that gentle, interested, validated, and easy-mannered, is actually a real gift to the person who needs help. It's also a good example. And then I think it's helpful to ask this big question. Are you happy with the life as you're living it now? Maybe somebody is. Maybe they don't want help. Maybe they like where they're at. Probably not the case. It's not for us, though, to make that decision. When I have clients that come in and they're kind of on the fence, and I tell them, well, this is what the protocol is, and this is what you can hope for, because here are the statistics for people getting better. And they say, well, I don't know if I want to do that. It's a lot of work. And I have to ask that question. Well, if you're happy with how things are going right now, then that's all that really counts. It's not for us to decide to put our values on somebody else. It's when they're able to say, my life has gotten to a place where I can't manage it anymore. And I'm ashamed, and I'm scared, and that's when we can say, okay, would you just do this one thing? And let's make the phone call or whatever it is that the intervention needs. That big question is kind of an intimidating one, but I think it's important as well. So those are ways in which we can be engaged with people. Again, this is, when we're trying to do the selling job, right? When they're kind of in this foggy place and they need help, we know they need help, and they're resistant for all the reasons that we talked about, doing these things is going to be a gift to them. And treatment options, especially as it relates to trauma recovery, DBT, this is all VA approved here, and it's evidence-based. So DBT with prolonged exposure therapy, it's tough, it's very effective. EMDR, which is kind of a reprocessing, going back through memories, and there's a variety of different ways in which they can, it helps people in terms of their neural pathways and adjusting those. Cognitive processing, that's taking more of the thinking patterns that you have and working with that. Present-centered therapy is more about learning how to be in the present, solve problems in the present as opposed to the past. And there's always medication, which oftentimes can be an important part of it. So I guess we're going to ask questions at the end. Is that right? Okay, well, let's do that then.
Thank you so much, Rick. And that was, we're grateful that you spent some time with us tonight and that you were able to come and give this presentation. I thought it was very helpful. Wish I'd have met you 32 years ago. I wonder if you all would like about a 10-minute break or so to stretch, maybe visit the resource tables. Would that be something that you would appreciate? Yeah, the restrooms, I think, are right around the corner to the left, and the resource tables are over there that way. How about 10 minutes? We'll see if we make it back in time. Thank you. All right, folks, we're ready to get started. Again, I wanted to introduce our next speakers, which are Char Lopez, our Behavioral Health Administrator at St. Croix County, and Kelly Ingan, our Public Health Administrator. And I'll let them share anything else they want to say about themselves. And here you go, Char.
Thank you. Yep, I'm Char Lopez. I am the Behavioral Health Administrator, and Bob stole my thunder. I was going to tell you about the Narcan kits, and I see some of you have them. St. Croix County is one of the Narcan Direct grantees. We work with the state of Wisconsin, who gets the Narcan from the federal government. And we literally have whatever we need until September 2022, which is only a couple months away. So I hope all of you have the opportunity to grab some, because this should be in everybody's bathroom cabinet. It should be in every single dorm room. It should be in everybody's work bag, and available to use. And what this is really a second chance. It's if somebody overdoses, it gives them a second chance to have that conversation with them. Without it, we might not have them here. So I hope you all have the opportunity. When you are in the resource room, which is a room full of heroes, I work with some of the most amazing folks who spend, not only with the county, but we're partners within the community, are there just showing you, showcasing what they do and what they have to offer. The other thing we have are, and again, this is at the behavioral, I think the Health and Human Services or the behavioral health table. These are the locks for gun locks. They are from the vet center. Phil wasn't able to be with us today, but he wanted to make sure that anyone who has a gun at home has this available to them. And make sure you just grab one of those as well. Also, there's candy. And this is something that we can just all wear that will demonstrate awareness for suicide prevention. So I hope you all are able to grab one of these as well. Kelly had handed out some, if you didn't get one, she'll come and give you one. But one of the things that really falls right into what Rick was talking about is how do we have these conversations? I've been in the business for over 30 years, and I have been a social worker, and I went to counselor school, and I've had really hard conversations with people I don't know, and that's actually kind of easy to have those conversations. The hardest conversations are with those that we love. And this is just, I took this and adapted it from the American Foundation of Suicide Prevention website. But I love it because it gives you words. It gives you words to practice, to try out, and it gives you everything from how do you start the conversation to how to get them to get help. So I wanted to make sure you all walked away with this in your hand so you had something for when you have to have that really hard conversation. I also attached the guide to the health services within Pierce and Polk County. This is an amazing collection of what's available, and by no means is this an exhaustive list, but it gives you the opportunity to see what's available. It breaks it down from mental health counseling, psychiatric services, psych testing, substance abuse, and then it also tells you what insurances or payment methods they offer. So these two things I think are just, if nothing else, if you have these at home and you have to have that conversation, you're ready to go. Okay, so I want to talk about what is available within St. Croix County. First, I'm pretty new to St. Croix County. I've only worked within the county for less than 2 years, actually. And this county is so resource rich. We are very lucky to have what we have here. Our neighbors, Polk County, Pierce County, Dunn County, they do not have what we have here. And much of that has to do with what we offer within the county. Really starting at the beginning, how do people access services? So we have staff that are people who answer the phones, and they will take questions, and they will take crisis, and they will take whatever comes on that phone and make sure that they get to the right people. So our information and referral staff, they're available Monday through Friday, 8 to 4:30 for walk-ins. You can call the access line, which I don't have on there, but is 246-8255. And that's for everything. And also we have everything available on our county website, so you can always go and look on there. We also have crisis response. So this is one area that St. Croix County definitely supersedes anyone in the area. We have partnerships with Hudson Hospital, so we have telehealth available where any hospital you go to in the area, including Amory, River Falls, Stillwater, all of the other ones in the county, when they're available, Hudson Hospital will provide telehealth and a telehealth assessment for anyone who is in a mental health crisis. The county also has a contract with Northwest Counseling and Northwest Connections, and they provide 24/7. So when we're not available, they're available to do the telephone crisis, and they're also available to do mobile crisis. This year, we were able to get 2 law enforcement co-responder positions through the ARPA, the American Response Plan Act, which allows us the ability to have 2 folks who are actually working right now, their hours are 3 to 11, to respond with law enforcement in a very quick manner. So when law enforcement is called out on a mental health crisis call, they are also called to respond at the same time. So they're there to be able to give a much quicker response than we've had in the past, and hopefully with a better outcome. That's what we're really looking for. Always with every crisis response, there is a social worker or a case manager follow-up within the first next business day. So if it's Sunday through Thursday, we have someone calling the next day, and if it's on a weekend, we're calling that following business day. Making sure to make sure they have their service connected, if they want services, to let them know how that can occur, and really offer any other services that are needed. Also through the ARPA funding, we were able to hire 2 community case managers. So working in the world of health and human services, we work under a lot of administrative rules where we have to do things within the rules of the statutes and the guidelines that we have. So these community case managers are really in the community, literally helping connect folks to resources in manners that we're not able to do within a clinic. They're able to, right now we have them very closely connected to Grace Place, to Onyx House, the food pantries, churches, schools, and really just trying to find the areas that are underserved and make sure that we provide those services to those that we don't normally, we can't normally get to. We also have one case manager that works in the government center. So we have a very unique setup here in St. Croix County. Most of our services are in Hudson, and then social services, our health and human services, is in New Richmond, which really causes a disconnect. So we've been able to have one staff who is, she's actually based in the government center, and she's working with those folks generally who are justice involved, but aren't necessarily connected to the jail or to probation or to the other services for pre-trial. Many of the clients she serves are in child support or in victim witness or something that isn't necessarily connected to jail. The things we have within the clinic is we have a psychologist, Dr. Ward. She does generally have a little bit of a waiting list, but not nearly the length of waiting list at other places. So right now, if somebody needs psychological assessment, you can be seen within about 2 months. We do have 2 psychiatrists. We have Dr. Simon, who has been talking about retiring for years and years and years, but we are so lucky to still have him. So he is doing everything telehealth, and he works with our healthcare campus as well. So his population, that's kind of his specialty is older adults, but he is amazing. He keeps our records busy. And we also have Dr. Plotz, and he does both telehealth and in-person services. We have 1 psychiatric nurse. We have 4 outpatient mental health therapists. Again, they do group and individual. They do telehealth and in-person services. And we have 7 outpatient substance use counselors. Many of the services they provide are court-ordered, but they also do voluntary services. Again, they also do telehealth and in-person services as well. We also have community mental health-based programs. So we do have a family-centered treatment service, and that is it's an intensive in-home intervention for families with children that are involved with children's services. We have the Comprehensive Community Support, the CCS program, and that is both youth and adults, and that's for those who are Medicaid eligible. And those interventions really focus on creating a network of support. And the cool thing about CCS is you can do things a little bit outside the box. So in the non-traditional type interventions, so you can do yoga, boxing, also you can do things like equine therapy. So things that can support your recovery that normally we don't think of as therapy. So it's a really cool intervention. We also have the Adult Community Support Services. So that's a service that is really for those adults who are living with chronic mental illness to really help them live their best lives and to be as independent as possible. And we have some targeted case management as well to coordinate some ongoing services. We do offer the ability to bill to third-party insurances. We have Medicaid and Medicare where applicable. And we also do a sliding fee scale, which makes it a little bit different than the private world. We have the ability to do that. We try to provide services to anyone who needs them.
All right. Am I close enough? Okay. Hi, I am Kelly Ingan. I am the public health officer and public health administrator is the official title at St. Croix County. So Shar really talked about what our behavioral unit or subunit within DHHS does. One of the things that public health does is really focuses on the community at large. So we aren't looking at individuals and situations that individuals may be going through. We do that, but on a larger scale, we like to look at data, as Bob alluded to earlier, and some other presenters, Patty. So we really do focus on data and different sources of data, to really tell us what problems might be happening in St. Croix County, or what things are going on. So one of the things, the biggest thing that when they said, hey, do you want to be on this panel? I said, not really, but I sure will. One of the things that stuck out most in my mind, what we do in public health is we are part of a community coalition called Healthier Together. And Healthier Together is a coalition that exists because of certain, like Shar alluded to, rules and statutes, and also hospital rules and statutes. So what Healthier Together does is assesses we do assessments every 3 years called community health needs assessments. And I found it interesting. I looked back a couple days ago. We do these every 3 years in St. Croix County. We also, the thing about Healthier Together, we are a 2-county coalition, so it's St. Croix and Pierce counties partner together to do this. As I look back at our previous 3 community health assessments, so almost 10 years of assessments, mental health has always been a top health priority. We just finished our community health needs assessment that will start in 2023 through 2025. And we have a new health priority titled, wrote it down, mental, social, and emotional wellness. So now we're going into another 3 years where the community has identified mental health as being a top issue for our community. I think it's important that you can understand this community coalition. We are a coalition that really involves a lot of partners as far as healthcare who may be providing direct services, our schools, our friends at United Way. There's a ton of partnership that goes into. What we are not is a foundation that offers money. It is really grassroots work to try to do, as Bob said, which we have had extensive conversations on, what we think might work. We can't keep doing that. We have to look at research and evidence that shows what works for communities given the identified problems. So I am going to go ahead and read this for you. This is our scope statement of Healthier Together. Mental wellness includes our emotional, psychological, and social health. It affects how we think, feel, and act. It also helps determine how we handle stress, relate to others, and make healthy choices. Healthier Together is focused on creating policy, systems, and environmental change that support mental wellness for all residents of Pierce and St. Croix counties and prevent mental illness from occurring. Mental health and physical health are equally important components of overall health, which I think a lot of our presenters have alluded to tonight. So that's really our scope statement for this new health priority. And a few other things Healthier Together as a coalition have done in the past is really bring in evidence-based trainings like Make It Okay and Mental Health First Aid to offer in a variety of different settings around the community. Some of those specific programs, Make It Okay really looks at reducing stigma of mental health. I think you've heard tonight, it is a hard thing to talk about. It's even a harder thing to talk about for some than others. We know there are at-risk populations that occur. So really being versed in that and being able to have the conversation. Shar, I'm going to keep your hand out right with me. I have a 13-year-old son at home who I worry every day about. So I think that is, why we're here. And one of the things public health does is really try to see the big picture and then design, as Bob said, strategies that'll work best in our community. The problem is we can't do that unless we hear from people in our community. So it does us no good to design interventions for others if they're not at the table. So we are really, really glad you came tonight, and hope to see you again at future events like this. That's it.
And if anyone has any questions, I'll come to you with the microphone. Not everyone at once.
Just a question about the number of people that committed suicides. How many of those people had been in either our county system, or do you think were receiving private health care prior to their suicides? In other words, did we know about them prior to their suicide, or did it just come and happen?
The majority of them are not in the system. That is something we've been doing for years, is whenever we do have a completed suicide, I reach out to Health and Human Services to see if they're receiving services. And that really alludes a lot to the stigma. And the same thing is said with our veteran suicides. They haven't reached out for county veteran services. So that's, again, talking about what we have. We need more champions out there to talk about the services that's in our county.
Thank you, Allison.
I don't get a microphone often either, so that's kind of fun. Bob, I think you maybe alluded to advocacy, and I think all of you have talked about policy and system changes. What can we as community partners or community members do to support that work that you may be doing at the county level?
Every legislative cycle, county organizations like the Wisconsin County Association, Wisconsin County Human Services Association puts together a legislative agenda to address priorities that we see as counties and to advocate on behalf of those counties for those changes. What everybody can do is, well, to be involved legislatively, pay attention to the topics that are coming up in legislative cycles, and think about calling your local representative, state senator. And while it feels like that doesn't make a difference sometimes, it honestly does. And when we're trying to push a legislator in a direction that we think would be helpful for these kinds of topics, hearing from their constituents is the primary reason why they do or don't follow our advocacy efforts. Just in general, what I'm interested in, and I think what other county administrator or county human service directors are interested in, is systems change. We want to look at ways in which to sustain a more robust behavioral health response and behavioral health care system. To do that, of course, you need consistent funding streams. You need some way to sustain efforts that you start, not grant funding. You can't grant fund healthcare. It's great for starting programs, and then when the grant funding ends, what happens, right? Sometimes they're sustainable, sometimes not, but things come and go depending on the issues of the day. We need a sustainable healthcare system, Medicaid funded, if possible, but connected and consistent in how we respond to behavioral health crisis, any behavioral health disorder. It needs to really mirror, and the physical healthcare system isn't perfect, but it needs to at least look like that. When somebody has a need in behavioral health, that they can go get the same kind of care without worrying about, is this covered under my insurance? In fact, and I won't go on and on, but there's things to advocate for that I think would be beneficial. Not speaking for the county here, but speaking as a professional in this field. Medicaid expansion would be helpful because it raises the level of the poverty level so that more people qualify for Medicaid and can get health care. That's one thing that it does. But really, beyond that, it becomes a push to say we need to have parity with physical health care. We need to have a system that's funded adequately, and it isn't currently. And we need to stop pointing the finger at people with mental health disorders as being the reason for mass shootings and violence in our communities, because it's not the case. And we need to instead invest in treatment. I don't know how to answer that more specifically other than please call legislators and voice your opinion about what you think would be helpful for your communities. And that's probably one of the best ways to advocate on an individual level.
My thoughts? I think coming from a death investigator's perspective, when we look at these cases where untreated mental health is involved, what we also see is very expensive medical conditions. So not only does it cost on the side of mental health, it costs on the side of untreated medical conditions. And some of the conditions that we see are horrifying, that we have people in our community that are living in situations because of their mental health and physical health is so bad. And then when you start looking at when they finally got into the healthcare system, how expensive it was, and they didn't have the resources. So it ends up costing everybody more when we don't take care of these folks. And, it wasn't until I became a death investigator that I even knew that we had people that regularly live in a lot of our hotels. That's their home. And they don't have access to food, they don't have access to health care, they don't have access to medication, which then impacts the decisions and choices they make when it's talking about their health care. And when they do, go to the doctor, a lot of times they're septic. So then they have to be in the hospital for a while. They may lose a limb. Now we have another physical problem. And it just grows and grows. And we're seeing more and more of this because of our aging population. There are a lot of people in our aging population that, have worked. They are working members of society, but they've always kind of lived in the background. And now as they're getting older, they're trying to figure out their way, and it's really hard that we don't have the resources to help them navigate a better situation, especially with the elderly, because by the time they do come to town, they're so chronic that it's so expensive. It is not fiscally responsible. And it's really sad, and we see it a lot. And when we see it in my office, all that stuff has already been, done. So it's really tough.
I could go on and on about PSC. PSC is what we call Policy Systems Environmental Change. It's a great question, and I think even talking about it, I think even speaking that language with partner organizations to really understand that good policy, whether it's a big P or a little p, whether it's huge that impacts things like Medicaid or transportation, there's all kinds of them, right? It's getting people to really understand that those policies and systems and environment really do shape the health of a community. So I better cut it there.
just like to thank you for sharing that, because, you know, at the grassroots level, imagine what it's like when you're working with somebody and they're doing well, they're doing better, and they lose their job, and now it's cut off. Or somebody who needs a higher level of care, and that's what they need, and that's what's going to get them better, and they feel that they can't afford that.
So good evening. Charlie Forbush here from Western Wisconsin Health, and I've been thinking a lot about, you know, the example that you brought up tonight about when folks come in with a heart attack, there's all that, you know, resources and efforts to help someone. And so this is really just a comment more than really a question. It's just really highlighting, you know, you talk about funding and some of the things that need to change from a legislative perspective, and that's just funding. You know, when you look at what does a visit reimburse for a mental health versus, you know, a ER visit from a cardiac perspective, I mean, it's not even close. It's $40 for mental health roughly versus, you know, thousands of dollars for cardiac. And so, you know, I think that is something that has to change. You know, I think that at Western Wisconsin Health, we're so fortunate that because we have a rural health clinic status, we're able to have a robust, you know, 9-10 provider behavioral health department. And I can tell you right now that if we didn't have that status, there's no way that we can pay our counselors and our other providers, you know, X dollars, and they're receiving $40 for an hour visit. So that's where we have to reach out and change that, you know, funding source, and, you know, grants, et cetera. They only take you so far. And I think that I just wanted to bring a different perspective of the reality there. So
I appreciate those comments, and Western Wisconsin Health has been very, we've been in talks with them about some projects and some efforts that we're undertaking. My take on this is, rather than, for me, I mean for the counties, rather than complain about the current system, let's create something with whatever we have available to us, create something that the state then can't live without and that the communities can't live without, and say, we did it, we created it with the grant dollars, fund it, so we can build a system locally that works and is going to work into the future. And that's been the case in the past when you talk about policymakers. Once you build something that's shown to do a lot of the things that Patty said, like reduce costs, reduced hospital admissions, reduced jail incarceration, and you start to show good positive results from the system you built or the project that you developed, it becomes very difficult to defund it then and say, well, we don't have any more money to pay you. And then you get community support because people say, we don't want to lose this, right? And that's what we're in the process of building here in St. Croix County. We're building through some of the things that Shar said with our community case managers and our co-responders with law enforcement and other efforts that are ongoing right now that we're developing that will add, that will come together as pieces of a puzzle to build a system of care locally. And then it's hard to take it away when it works. And we thank you for coming tonight. We thank you for those comments and just for being a good partner with us. Thank you.
Sometimes you have to really think about preventative health in a way that touches you personally. So my husband is a hot mess. He's had 4 heart attacks. He has 17 stents in his heart. He's a diabetic and he has rheumatoid arthritis. He's on 14 different prescriptions and he was just prescribed Remicade. Remicade is an injection once a week, and he called our insurance company and it's $1,600 per shot. So we have good insurance. Now, there are lots of people out there that are a hot mess like my husband, and we love them dearly. But just think what it's like if you can't afford that. So now you have to make a decision. Are you going to, deal with the chronic pain that rheumatoid arthritis gives you, or, stop taking your cardiac medication or your diabetic medication so that and these are the things that are happening throughout our county with, we're living a lot longer. Technology has done a really good job, and medical innovation has done a really good job of keeping really sick people alive for a really long time. With that comes a responsibility to, understand what that means. So when you get to that point in your life, as we're getting older and you no longer have those resources, it becomes decisions and choices. And that's an inlet for a lot of the mental illness that we're seeing with our older folks.
Can I add to your comment, Patty? I'm going to share with the group. I've been a type 1 diabetic. My name is Carrie. I work for United Way. I've been a type 1 diabetic since I was 2 years old, and I've been through a lot. I can totally relate. But with that, also part of what we're talking about today, I think needs to be also something that's addressed, whether you're teeny tiny or very old, with any chronic health condition, needs to also come a conversation with the mental health piece. Because that is huge, not only for that individual, but everyone around them too. And it really impacts, it's no different than the same conversations all of you were talking about. It's hugely important, but it's part of that healing process as you deal with that too. And that also comes to our community. It comes to all of us. We all know somebody, love somebody, whether it's diabetes, cancer, or something else. It's important as part of that mental health piece that we need to address.
Hi, I'm Julie. I own Onyx Sober Living in New Richmond. I have homes in Polk and Dunn County now as well. But my question to you guys, when we're talking about suicide prevention and mental health, I have sent a lot of guys to the ER with suicidal ideation with a plan. And they get to the ER, and either they change their mind about what their issue is, or the ER staff says, we think you're fine. I've actually done it with my husband. I took my husband to the ER. They sent him home to me. I called up the therapist and chewed him out. So as community members, when we are struggling with addressing mental health with our families and neighbors, how can we advocate that in the hospital? Do you guys have any suggestions?
So I just want to start by saying Wisconsin's laws are not, it could be better. And there needs to be advocacy from folks who experience things like you. In other states like Minnesota, it's much easier to access services, and we need to work within the rules and the statutes that are put forth in Wisconsin. We always have the ability, anyone has the ability to seek voluntary hospitalization, but as you know, when somebody gets there, they sometimes change their mind. And the laws which we have right now, we have to go with the least restrictive options, and there's a lot of criteria that need to be met with dangerousness, intent, and without that support, we can't go there. And it is frustrating, and it's frustrating. I get calls from parents who are with a very similar story to what you're just saying, and it's heart-wrenching to hear that when they have adult children who aren't willing to participate and such. So advocacy when we're marching down to Madison, this needs to also be on the agenda.
I would just add one thing to that, is that these partnerships between behavioral health or human services and hospitals is a beginning step to helping develop urgent care for behavioral health, right? So you have professionals in that instance where you have, and we had this in Minneapolis, but you have an urgent care where you bring someone in some kind of crisis, and those therapists and workers are trained to talk with them in a way that assesses their situation. And I'm not saying doctors and other healthcare professionals don't have that skill. I'm not saying that. I'm saying that this is designed for people in that situation to assess them and talk to them in a way. Take the time to explore with them what's going on and help them get what they need. It's a step in that direction of providing a better level of care. And we need our partners at hospitals and doctors and physical health care to work with us and combine our efforts so that it's more of a blended system of care to that extent.
I think that might be it.
Okay. I want to personally thank all of you for taking the time tonight to come to have this discussion. I hope it was helpful. I hope it had some meaning. And it's not our intention to just say words and show data. It's our intention really to try and engage all of you in this kind of conversation so that we can do better. We have some of the best people I've ever worked with at the county who are devoted and compassionate, and people like Rick, who is phenomenal, and I wish he was in our county. But there's people out there doing their best to address this issue, and we still understand that's not good enough, right? But it's not the people, it's the system of care that we need to improve, and we're trying to, and going to, but we need your input. As Kelly said, we can't do it without your input. So thank you all for coming. I hope you have a very lovely summer evening, what's left of it, and good night to everyone. Thank you.
I would just like to say thank you to Supervisor Long, Supervisor Fiedler, and Supervisor Telejohn for taking time to listen to not only what we have to say, but the people in St. Croix County. We really appreciate that you showed up.
Thank you.